I invite the chairpersons for the next session, Dr. Ketan Mehta, private consultant in Mumbai, Asian Heart Institute, Sorplus Hospital, Dr. Ballabhai Navati Hospital, Seven Hills Hospital. Dr. Baira Reddy, Professor of Medicine, Rajarajeshwara Medical College, Bangalore, and Dr. Maben, Professor and Head of Department of Medicine, AJIMS, Bangalore. Kindly take your seats. I invite our speaker, Dr. Narayanan Namboodiri, onto the dais to speak on sick sinus syndrome, sinus node dysfunction, varied presentation and how to recognize it. I request the chairpersons to introduce Dr. Narayana Namboodiri.
Good afternoon, everybody. The first session in the afternoon session, and we have none other than Dr. Narayanan Namboodiri, which of course is a well-known figure in of course this part of the country. He is the Associate Professor of Cardiology from Sree Chitra, Tirunal Institute for Medical Science and Technology, Trivandrum. He has done a fellowship in EPA from Australia. He is a section editor for Indian Pacing and Electrophysiology Journal, had a lot of publications in national and international journals, and he is also Honorary Secretary of Heart Rhythm Society Kerala chapter. So with these words, I would request Dr. Namboodiri to start on. He would be talking on sick sinus syndrome, sinus node dysfunction, varied presentation, and how to recognize it. Thank you.
Respected chairpersons, senior physicians, and friends. It is not uncommon to see a patient with a sinus node dysfunction in general clinical practice. A typical patient presents with a history suggestive of cerebral hypoperfusion in terms of frequent pre-syncope, post-syncope, and an ECG, 12-lead ECG or a Holter which shows significant sinus pause or sinus arrest. But this can also present in many atypical forms. Let us start with a illustrative case. This 21-year-old medical student, a dental student, presented with a history of 3 episodes of syncope within a period of 6 months. Patient had a history of recent onset seizures prior to onset of these syncopal episodes and was on regular treatment for the same. No other neurological symptoms were noted during these transient loss of consciousness episodes. The electrocardiogram at the time of presentation showed sinus arrhythmia. A provisional diagnosis of symptomatic sick sinus syndrome was made. This was the Holter recording, a significant sinus pause of 3.3 seconds corresponding to the pre-syncopal episode. So this patient was admitted for a pacemaker, and while we copied the treatment records, we just noted this patient was on carbamazepine 600 milligram per day for seizures. This was immediately replaced with a lamotrigine. Carbamazepine is a sodium channel blocker which can affect the sinus automaticity, we know, and he has remained asymptomatic for the last 7 years. So sinus node dysfunction, sinus node is probably not the only culprit. In this talk, I will be discussing about what sick sinus syndrome or sinus node dysfunction is, what are the typical as well as atypical presentations of sick sinus syndrome, and how to evaluate a patient with a suspected sick sinus syndrome. We know sinus node contains 2 types of cells. One is responsible for the automaticity in form of P cells, pacemaking cells, and another set of cells called transitional cells which mediate the transmission of this impulse from the sinus node, that is a site of formation of the impulse, to the surrounding atrial tissue to result in P waves. So there could be 2 pathologies within the sinus node, that is inability of the P cells to produce an impulse which is called sinus, which results in sinus pause or sinus arrest, and the other one, that is impairment of transmission to the atrium resulting in sinoatrial exit block. If you take statistics based on the electrophysiological studies, sinoatrial exit block is much more common than impulse abnormalities in impulse formation. We know the pacemaker cells are characterized by particular channels called funny currents, funny channels, and also they have got a slow diastolic depolarization which can account for the automaticity specific to pacemaker cells. Apart from this sinus node automaticity, sinoatrial junction conduction as well as autonomic tone can result in various sinus arrhythmias or abnormalities of sinus node function. Sick sinus syndrome is a wide spectrum of group of disorders caused by a malfunctioning sinus node, which manifest in ECG as sinus bradycardia or sinus pulses, which could be sinus arrest or an exit block, a tachybrady syndrome, and chronotropic incompetence. We'll come to them one by one. And the burden of the problem, it is quite common in patients aged more than 50 years to the degree of 1 in 600, and it accounts for nearly 1/4 to half of pacemaker implants across the world. The commonest causes can be divided into intrinsic as well as extrinsic, and intrinsic ones are idiopathic and degenerative, and the extrinsic ones, we know clearly that hypothyroidism can result in sinus bradycardia, electrolyte imbalance can result, and similarly situational syncopes can occur with associated, though they are not primarily sinus node abnormalities and not uncommon to see a patient with a carotid sinus hypersensitivity neurocardiogenic syncope. But probably the most important ones are related to drugs like antiarrhythmics, antihypertensives like beta blockers or non-dihydropyridine calcium channel blockers, SSRIs, very common prescription, and lithium, and as I mentioned, sodium channel blockers like amongst antiepileptics, carbamazepine, phenytoin, and sodium valproate. In the newer antihypertensives, clobazam, as well as lamotrigine, gabapentin, levetiracetam, they are all uncommon. They don't impair the sinus node function. I would like to mention that particular point. They present with a history suggestive of cerebral hypoperfusion varying from lightheadedness to syncope. This is a patient who presented with the EC fatigability, and the ECG had shown sinus bradycardia. As Dr. Green had already mentioned the degrees of AV blocks, even sinoatrial block can have varying degrees of conduction abnormalities. The type 1 is a delayed conduction, and type 2 is nothing but dropped, which also could have type 1, which is Wenckebacking, and type 2 where it results in sudden failure and high degree block and dissociation when you have abnormalities in sinoatrial conduction, totally dissociated. Unfortunately, in an AV block, you can see the atrium represented by the P wave and ventricle represented by the R wave. Here the depolarization of the sinus node is not represented in the ECG. So when you have a prolongation of the conduction from the site of impulse formation to the atrium, it is not manifest in the surface ECG. So as third degree SA block, when you have dissociation between them, usually it presents as junctional rhythm and it cannot be diagnosed on surface ECG. On the other hand, if you have a sinus block rather than a sinus arrest or SA block rather than a sinus arrest or a sinus pause, we can infer the presence of this SA block while calculating the PP intervals. If it is the multiples of the basal PP interval, you should suspect a SA block because the automaticity continues on at regular PP interval, and once it gets blocked, only that particular beat is missed. And of course, grouping of beats would give clue to the second degree AV block. And in a type 1 second degree SA exit block, there is progressive shortening of the PP intervals till it beats from the sinus node fail to activate the atria. And type 2, it remains fixed till one gets blocked. There is no universally accepted definition to differentiate between sinus pause and sinus arrest, though when you have a significant prolongation, we call it sinus arrest. Apart from these typical presentations, we can have atypical presentations of sinus node dysfunction in many clinical settings. One important condition is in the setting of ischemia, when a patient has an inferior wall MI or secondary to drugs, as I showed in the illustrative case, and pauses at the termination of tachyarrhythmia. Patient presents with atrial fibrillation or atrial flutter, which probably remains asymptomatic. When the flutter or the fibrillation terminates, these patients present with a syncope due to the time taken for the sinus node to recover, which is already suppressed for a longer period of time. The longer the degree of suppression, duration of suppression or duration of the tachyarrhythmia, the longer would be the recovery time taken by the sinus node as well. and the tachybrady with the pauses. Another one, atrial flutter or fibrillation masking an underlying sinus node dysfunction. Patient comes for atrial flutter ablation. We ablate the atrial flutter, and the patient goes back to, goes junctional bradycardia with no sinus escape, and they become more symptomatic and great masquerades like hypothyroidism. This 72-year-old lady with inferior wall MI, last week admitted to our ICU, post PCA to RCA, had stent thrombosis. PCA was done outside and was admitted with a stent thrombosis and recurrent, re-MI. It shows an atrial fibrillation with a fast ventricular rate. When the atrial fibrillation terminates, you can see a prolonged pause. AFib terminates here, a 10-second pause here. So what could be the cause? The contributing factors could be sinus node suppression related to atrial fibrillation. As I mentioned, the atrial fibrillation, there is a sustained atrial arrhythmia going on, sinus node gets suppressed, the funny channels gets down-regulated, and it takes longer time for the sinus node to recover. Second is the ischemia related to RCA involvement and sinus node ischemia, and the drugs for atrial fibrillation. And after the termination, we put the patient on amiodarone 100 milligram per day and metoprolol. Last 5 days, no tachyarrhythmia and no subsequent bradyarrhythmia as well. So the contribution from the initial two might be more important than the third one. Sorry for the clarity. We can see the this an atrial flutter with a varying AV conduction. We can see the P waves here, and it shows a very low amplitude P waves. This patient had a fondant circulation, a lateral tunnel within the atrium. With this scar, this is a scarred area, and extensive scarring of the sinus nodal region. We ablate it and results in pause. This is another condition where the underlying sinus node is diseased, and at the time of discharge, patient is in junctional rhythm. We can have great masquerades like hypothyroidism, drugs I mentioned, carotid hypersensitivity, and athlete's heart. A 16-year-old boy with a dyspnea on exertion class 2 and presyncopal episodes. We can see the tachycardia going on, results in pauses at termination. And if you have a closer look, you can see the tachycardia terminating at the P wave. So it is not an atrial tachycardia. There is no reason for the atrial tachycardia to terminate the P wave. The last beat of the tachycardia gets blocked also in the AV node. Two unrelated events happening simultaneously. So it is not an atrial tachycardia. So there are some reentrant beats as well. So significant pauses. This was taken during a sustained phase of tachycardia. This turned out to be a PJRT, or persistent form of permanent form of junctional reciprocating tachycardia. So coming to the evaluation of these patients, the goals of this evaluation is, it's based on two important aspects. That is to confirm the diagnosis. For that, you need to show the relation between the sinus pause and the symptoms. The cause-effect relationship should be shown before we decide on further therapy, and to establish the etiology also if possible. There are many ways to demonstrate the pause. Routine ECG is a snapshot. You may or may not get any abnormalities with the P wave. In 24 ambulatory ECG, you may sample nearly 1 lakh beats. Tilt test useful in vasovagal, and stress testing and pharmacological testing to look for chronotropic incompetence. Adenosine test is not usually done. And the most important one amongst this entire one, apart from ECG, would be an external and internal loop recorder. An EP study has got a limited value. These are the diagnostic modalities recommended in the ESC guidelines. So as I mentioned, it is important to know what occurs during a spontaneous event. That is the gold standard for diagnosis. And if the patient has got infrequent and transient symptoms, recurrent over weeks or months, are unlikely to be diagnosed by a 24-hour snapshot. So the longer the duration of monitoring, the higher the chance of picking up the events. So we can see always a ILR, implantable loop recorder, would be much better than a 24-hour Holter. This lady with the sinus bradycardia and sinus pauses, on Holter, you are lucky to get a documented sinus pause. So if the frequency is, almost daily, a 24-hour Holter would do. If it is every month, an external loop recorder, an extended period would be much better than. Despite all preliminary investigations, in 30 to 40% of the patients, the cause of syncope may still remain undiagnosed. So you need extended monitoring using loop recorders. Loop recorders have a retrospective memory which continuously records and deletes the patient ECG. It has got two components. One is an auto activation feature. If there is a pause as predefined, let it be 3 seconds or more than 4 seconds, it records the event. And similarly, patient can activate this event if the symptoms develop. They underline that particular episode. This can be an external loop recorder or an implantable loop recorder. ELR is indicated if the patient has got recurrent pre-syncope or syncope with an inter-symptom interval of less than 4 weeks, suspicion of arrhythmic origin, and absence of high-risk criteria that require immediate hospitalization or intensive evaluation, which otherwise would be indicated for an immediate pacing or hospitalization. So patient with amongst sick sinus syndrome, if you have a symptomatic patient with a sinus bradycardia of less than 50 beats per minute, in the absence of negative chronotropic medication, you should not subject to ELR. These patients become directly a candidate for pacing. Let us see two cases. This is a case of transient loss of consciousness. A 6-year-old girl with frequent episodes, multiple evaluation, nothing came out. It's so transient that nothing could be recorded during events. And on day 14 of external loop recorder, patient had clinical symptoms and the ECG was absolutely normal. So this has got a high negative predictive detection value, and the symptoms were labeled, diagnosed as functional. When you have an implantable loop recorder, the longevity is quite high, 36 months, and it records much more EGMs. Obviously, you have device-related problems. You need an implantation procedure. You need an explantation procedure. But the evaluation is done by the implanter in this case. In ELR, the implantation as of now, it's done by an external external evaluator. This is the implantable loop recorder by which is called Reveal, the simple incision at second intercostal space. This is a patient activator. You can have a patient activation as well as automatic activation, and you can predefine the duration to detect it as asystole, 3 seconds mentioned here. And this is a pause detected in an implantable loop recorder. A case of transient loss of consciousness, another one. A very sick patient, 72-year-old male, diabetic for 30 years, post-CABG, history of MC infarct, multiple episodes of transient LOC. We did all evaluation, neurology, heart, invasive EP study, everything normal, but still continue to have, we put an implantable loop recorder. An ideal case because it happens only once in 3 months, 2 or 3 months, and within 1 month, it's quite surprising. You can see 38-second pause. This was during sleep, and the patient had noticed to have a seizure-like episode, and 38-second pause without any sinus node activity. You have to believe it because it's an implantable loop recorder, and it will give very clear electrogram, and there is no scope for detachment. This patient received a pacemaker. And coming to the last part, it's electrophysiological study. It has got only an adjuvant role to clinical findings. None of the indications for permanent pacing actually uses information from electrophysiological studies. And most methods used, whether it is a sino-atrial conduction time, whether it is sinus node recovery time, corrected total recovery time, whatever it be, these tests provide only indirect and impure analysis of sinus node automaticity and conduction. These are the usual values we look for. And another one is to do an atropine test. And if it is greater than 90 beats per minute and it increases over the control rate of around 20 to 50%, we assume sinus node response. Whatever we have noted, the bradycardia is due to autonomic dysfunction. In lab studies also we have to do, like thyroid function test, all these patients, we have to exclude this patient is not on any drugs, serum electrolytes, ESR, as we have seen, collagen vascular disease can even present with sinus node abnormalities because of, and some infiltrative disease like sarcoidosis, amyloidosis, hypercalcemia, hyperkalemia, and other directed investigations as per clinical suspicion. And also important to note that to pace these patients as per class 1 recommendation, you need symptoms. You need only symptomatic patients would require pacing in case of sinus node dysfunction. So ladies and gentlemen, My conclusion is that sinus node dysfunction can have varied presentations, and it is important to recognize them for proper management of these patients. The correlation between sinus poses and symptoms, it is the cornerstone for diagnosis. An EP study has got a limited role in the evaluation of sinus node function, and always rule out reversible etiological factors before you pace a patient. Thank you.
Thank you very much, Dr. Namboodiri. I am sure your talk stimulated all of us to have a relook into the sinus node. Now the topic is open for discussion.
There is a test which they do the total abolition of parasympathetic influence on the SA node by giving atropine.
Yes, sir.
And then total abolition of sympathetic this thing by giving beta blocker.
Yes, sir.
I would like to know, when do you do this test, and do you do it in your usual practice because you are a EP man?
Yes, sir.
And does it really help, and what are the indications for this? Is it a good
Sir,
test?
as of now, it is not recommended. It's not routinely done. It's called intrinsic heart rate assessment. What we do, we take off both sympathetic as well as parasympathetic influence on the sinus node, so that you know whether sinus node is intrinsically normal or abnormal. The process is to give 0.2 milligram per kilogram propranolol over a 10 minutes period and wait for 10 minutes, assess the sinus nodal active rate, then give 0.04 milligram per kilogram atropine and to see the sinus activity. The standard one is 118 minus 0.57 into age. If it is more than that, it usually comes around 107 or so. If it is more than that, sinus nodal activity is absolutely normal, and whatever bradycardia you have noted is due to excessive vagotonia. Many times, if you give atropine and take off the vagotonic effect, and if the heart rate goes beyond 90 to 100, you know it is clearly related to the vagotonia. So you don't have to give propranolol in addition to atropine. And people had problems by giving IV propranolol and atropine, and it has to be done in an electrophysiology setting. And exercise testing is as good as, or atropine is as good as, intrinsic heart rate assessment. Thank you.
On the surface ECG, how do you differentiate between sinus pause and sinus exit block?
Sinus pause
and sinus exit block on a surface ECG.
Yeah, I have already shown that slide, but because of brevity of time, I just if you show it is multiples of PP interval at basal, you can clearly diagnose a second degree type 2 SA block. And type 1 you can diagnose by fusion, that is grouping of PP intervals. I'll just show that. Because you cannot see the onset of the intrinsic the electrograms at the sinus node. You infer this by indirect grouping of the P waves. Here, this is the second degree type 1 sinoatrial block. You can have, when you have a typical Wengi-Back with AV block, though often we see the AV prolongation, you should also note that RR interval shorten. Here you cannot see the equivalence of the P wave, that is the sinus nodal activity. So you infer based on the shortening of the PP intervals and losing one particular P wave in type 1, and in the type 2 the PP intervals remain same, and whatever the PP interval you have is multiples of baseline PP interval. This is the way it is shown. You have, and if it is not multiples, it is a sinus pause. A sinus pause could also be due to, but it's basically a sinus arrest. The importance is that sinus arrest you denote automaticity losing the automaticity, and in sinus exit block the abnormalities with the conduction. Thank you.
How much importance do you give to the mortality risk of out of sick sinus syndrome? What is the actual mortality risk out of sick sinus?
The studies done prior to, in the 80s had assessed this, and no study had shown significant improvement in mortality with the paced and controls. That is why the level of evidence is C even now.
Another question is, how do you assess chronotropic incompetence during stress testing?
Stress testing, if the expected heart rate 220 minus age in 80% less for females, if you achieve 70 to 80% of the heart rate, you diagnose there is chronotropically competent. If it is less than 80%, you can let
How
it
long
go.
exercise you do? We do by 85% target heart rate to achieve the during exercise for assessment of the ischemia. But how do you assess it? What percentage of patient his exercise may limit?
If the patient cannot exercise as such, you can give atropine and assess. For atropine, it is around more than 100 beats per minute. It is considered as chronotropically competent. Then,
if there are no questions, we will close this session. Thank you very much, Speaker.
thank you.
Thank you, sir. I now request Dr. Ketan Mehta to hand over a certificate to Dr. Narayanan Namboodiri. And I request Dr. Narayan to hand over the certificates to the